All right, well, I'm going to go ahead and just, it's good to see you guys, and we're going to just go ahead and get started. If anybody pops in, we can let them in and join us as they come in. It's good to see your faces. Those of you who I can see your faces, the rest of you, welcome. If you want to have seen your face, please feel free to start your video. I'm really excited today to have Cindy and Elizabeth here with us. They are from Care Weavers. So this has been a program that I think was trying to schedule a long time ago, long before we had to shut down the Y. And I'm really glad that at least virtually we can make this happen, because this is one of those things that I think can benefit everybody, whether it's for yourself personally or whether it's for a loved one or somebody you know, just sort of navigating all of this. So I'm excited to introduce Cindy, who you can see there. Wave, Cindy, so you can see Cindy up there, and Elizabeth Pruitt down here in front of this beautiful scenery. And I'm going to turn everything over to you guys to go ahead and get started.
Hello, Jane. Can you hear me?
I can, Versha.
Thank you.
Hi.
All right, I'm going to put you on mute. It's so good to see you. I'm going to put you on mute for just a moment so we can let Cindy.
I will put myself on mute.
Okay, and if you have a question, feel free. We have a smallish group, so if you have questions, if Cindy and Elizabeth are great with that, we can just stop, ask questions as needed. Okay.
Yeah, I think that's a good idea. I usually like to have people ask questions as we're going through some of the content, because it helps to be more relevant at that time. Sometimes when you wait till the end, people forget what their question was. So please feel free at any time to ask questions. So I'm Cindy Hostetler, and Elizabeth Pruitt and I are co-owners of Care Weavers. Care Weavers is a healthcare advocacy and navigation service for older adults in the greater Charlotte area. And Adrienne's already familiar with a navigator, and she said that was one of the things that really helped her. She had a diagnosis that was challenging to manage, and that's one of the services that we provide with our business. We can help you navigate the healthcare community. We go with people to physician office appointments. We can be with them in the hospital to advocate. We do in-home care coordination. So when someone's leaving the hospital or leaving rehab and they need continued services at home, we can help get all the right resources into your home and help manage the logistics of that. So without further ado, I'll go ahead. We have a lot of information to share today. And again, feel free to ask questions as they come up, and we'll do our best to get you answers. And if you ask us something that we can't answer, and that usually happens in every presentation that we do, I'm sure that Jane will be able to get us your contact information, and we can share that after the session. So right now I'm going to go ahead and share my screen with you. Is everyone able to see the screen right now?
Mm-hmm.
Everyone on with the screen? Okay, good. Okay, good. We'll go ahead and get started then. So the first thing I want to talk about is what we're going to cover today. What is an advocate? Why is it important? What are the basics about advocacy? Knowing what to expect, and roles and motivation in the healthcare system. Sometimes just understanding what kind of drives the different segments of the healthcare system and what their focus is helps you become a better advocate, so you know what you're working with and how to get the most out of those engagements with physicians and other people of the medical team. That orange symbol at the bottom, this was a presentation we've done a couple of times, and the COVID-19 was not present at that time. So when you see that come up, it's just an alert to say this is something that's different right now because of COVID. So first of all, an advocate, you know, you're pleading for a cause either for yourself or on behalf of someone else. What is a healthcare advocate? An advocate in healthcare system can be anybody. We are officially board certified healthcare advocates, professional healthcare advocates. There are more and more of us coming up in terms of starting businesses. And right now there's not necessarily a prerequisite for what kind of formal training you need to have to take the advocacy exam. Both Elizabeth and I are registered nurses, and we've worked our entire careers in the healthcare system. So we really understand how the system works and what doesn't work, and then we hopefully can avoid some of those pitfalls for our clients. But you can be your own best advocate as well. You don't necessarily have to have any formal training. I think the main things that you need to understand is how the system is designed and how it works at a very high level. You have to be confident and not easily intimidated because we speak in a different language. I was on a call the other day. Oh, I know what I'm doing census enumeration, and I was on a call, and they're using all these different acronyms for all these things that the government references census enumeration with. And I thought, wow, now I know what it feels like to be a layperson in the healthcare community. Yes, we use acronyms all the time and just assume that everybody knows what we're talking about. Always have the ability to question and understand fully before you make decisions. And sometimes that means holding the doctor a little bit longer and saying, now, help me understand exactly what you said, because this is what I thought I heard, but I need you to clarify it for me. And then also people that work well with a team. System, as you know, is costly, complicated. We, as a developed country, have some of the worst healthcare outcomes of any of the other developed countries, and we spend more on our healthcare than most other people do. This system is not designed for you and me. It's designed for the people that provide the care. And that's what we need to change as healthcare consumers. So that's one vital role of what needs to happen. This is a funny, please don't waste the doctor's time with any questions. And sometimes you probably feel like this when you're in the office, because they're on a model for payment that incents them to have as many people through their office on a daily basis as possible. That's how they make money, and that's how they get reimbursed, and that's how they get bonuses, at least one way they do. Some things to keep in mind, especially right now. If you do not have a healthcare power of attorney, someone that you have formally designated who is going to speak on your behalf in the event that you cannot speak for yourself, please, please, please do that. It is extremely important. You can go out online and we can get you this information later. You can download the forms right off the state website, and then you can get them. You just have to get an affidavit and a seal saying that, you know, they're accurate and true. You can also have them done by your attorney if you don't want to do that. But it's very, very important, because healthcare situations are usually never black and white. There's always some gray. And that's why it's important to name someone who can speak on your behalf, because they can ask the right questions that you would ask if you were able to do so. We also are pleading right now, make sure that you have a short little synopsis available in your home in the event that you need to go to the hospital, because right now, if you go to the hospital, there are not going to be anyone able to represent you. Families not permitted to visit, healthcare advocates are not permitted to visit, so you're kind of on your own. And that's why we've created a little abbreviated health profile. And to get that, all you have to do is go out to our website, send us your contact information, we can send it to you. One thing, how many of you use online healthcare portals from your physician's office and from your healthcare system? One, any more?
I do.
Great. Strongly, strongly encourage you to do that. There is a wealth of information out there, including the doctor's notes, which otherwise you wouldn't know necessarily. I mean, they will highlight the high level things with you, but there's also things out there that are very important, and it also allows you to keep a good record of your medical history. When you're going to see someone, make sure you have a list of questions, refer to it during your visit. And if you feel like you're going to be there for a prolonged period of time, maybe because you want to discuss your advanced directives with them, let the receptionist know when they're scheduling you. Say, hey, I'm going to see Dr. Smith today, and I'm also going to want to go over my healthcare directives with them. So could you please schedule a longer visit? They're able to do that because they can bill for that extra time. The other thing that we always emphasize is a lot of times physicians, based on a diagnosis, will say, this is what we need to do. And they go down through a list, and these are procedures we'll need to do. It's really important before you make decisions about procedures, surgeries, anything like that, that you understand the benefits of treatment as well as what is the consequence of not treating it. Because not treating it can be an option as well. And that's an important question to have. If I have X, Y, and Z, what does it look like for me if I don't choose to treat this right now? And feel free, I'm probably rushing. So am I going too fast for folks? Right pace? Okay.
You're fine.
Okay, good. So this is what we call the continuum of care. So over here, you see, we take you from the office space with your primary care physician in the event that you have an emergency, go to the hospital, get discharged, then you might need rehabilitation or skilled care. And then we have a couple of very brief slides just based on palliative care and hospice, as well as living communities, I'm sorry. And living communities are things that we classify as assisted living, memory care communities, etc. Some things just to be aware of that kind of shape our healthcare system today. So healthcare has come kind of a long way in terms of how it's evolving its payment structure. So there are still some what we call fee for services. So when you go to the hospital and they bill for a fee for service, it means that that hospital system has already negotiated what they're going to pay to an insurance company for that particular procedure or service. And there are some things out there that still work that way. One of those is a hospital emergency room visit. What we're moving toward is the government has recognized that Medicare, which is the biggest healthcare provider in the United States or insurer, and most other insurance companies follow Medicare lead, is that we're spending way too much money on healthcare for the outcomes that we're seeing. So what they're moving toward now is population-based payment, or shared savings and bundles. And what that means essentially is hospitals that have big systems like Atrium and Novant, what they're doing is they build out every aspect of that continuum, so to speak, so that it's all within Atrium's scope. And what they try to do is they try to keep you within that system because that's where their revenue is going to come from. But remember, you don't have to stay within any system. There are advantages and disadvantages of staying in a system. One of the advantages can be that your physician and your hospital and even your potentially where you go to rehab, if it's acute rehab, those medical records are more integrated than if you go to different individuals and providers outside the system. But the downside to it is sometimes these big systems aren't necessarily the best at providing all those segments of care. And when we talk later, I'll give you a couple of examples for that. The other thing that's happening right now with doctors are being held increasingly accountable for their outcomes. So it used to be you could just bill Medicare and they would reimburse you a certain negotiated amount. Well, now what they've said is if you don't meet certain quality indicators around our high-risk populations, like people who have diabetes, congestive heart failure, hypertension, etc., we're going to leave money on the table and we're going to take it back because you failed to meet the outcomes for the patient that you're supposed to be able to meet. And there's checklists for things. So if you are diabetic and you go into the office, that physician is going through a Medicare generated checklist of all the best practices around treating people with diabetes: vision assessment, foot assessment, measuring your hemoglobin A1C. And if they're not checking off all those boxes or documenting why they didn't do something, Medicare is going to withhold money from them. So we are moving into more of a risk-shaped model. So risk is on the physician side, but it's also on the consumer side. Many of you, well, I shouldn't assume. If you're in Medicare right now, you can get different types of premiums to pay, and you can range it anywhere from a low premium to a high premium. Typically, what we see, whether it's Medicare or insurance, is when you select a high premium, your total cost for your deductible goes down. If you select a low premium, your total cost for a what I just said the word, now I'm forgetting it. Your deductible goes up. So for instance, I'm in a healthcare plan right now that has a medium, middle of the road kind of premium, but my healthcare deductible is over $7,000 a year. So what that means for me is then I have more onus and responsibility to keep myself healthy because I don't want to have to pay $7,000 out of pocket. So first thing we're going to cover is deciding where to go. And this is especially important right now. And that's why I included this slide. Because of COVID, we know and we've heard there are studies right now that have demonstrated that people with very serious conditions are not going to the hospital as soon as they would have prior to COVID because they're afraid that they're not going to see their family again. And that's a real fear, and it's also valid. I get it. But by waiting, in some cases, they are doing more danger to themselves by waiting, by not getting treated. So what I wanted to cover today, physician office, if you think you might have COVID, for example, have any of you been tested for COVID or thought you might have the symptoms of COVID? Okay, great. That means you guys are doing all the right stuff. So if you did have signs and symptoms, the first place that we want you to start is to call your physician office, because they're going to assess you over the phone, or maybe they'll have a visual or a virtual visit with your phone. And then they're going to help direct you to the next thing that you should do. And in some cases, they're going to recommend that maybe you go to a mobile area or a dispatched area that's out away from the office to be tested, and see if you really do have COVID. Of course, cold, flu, chronic disease, that's who you go see your primary care physicians for. Urgent care, anytime, if you're over the age of, I'm going to say 50, and you slip or fall or have a strain, you really should go to the urgent care, because they have more diagnostic equipment there than your physician has. Physicians don't always have x-rays in their office. They might not have the ability to do ultrasounds, et cetera. And then the emergency room is really for true emergencies, any kind of abdominal pain, chest pain, shortness of breath, signs of a stroke, major fall, uncontrolled bleeding. But we always encourage all of our consumers and clients to always err on the side of caution. It's better to be safe than sorry. There was one about the stroke. Overreaction is the only reaction, right? If you feel like you're having a stroke, overreaction is the only thing that you should be thinking about. You immediately call 911 and you go to the hospital. So here we have the emergency triage nurse. Being the worst makes you first. So we also know that emergency rooms are often used as primary care physician offices, particularly for uninsured patients. Both the healthcare systems today have the ability to tell you what their wait period is at any of their emergency room areas. So if you're not in a life-threatening situation, you may want to take a look at that so that you're not having to wait as long. Goal is to avoid having to go to the emergency room altogether, having things handled by your primary care doctor or an urgent care center if that's possible. So the next couple of slides are going to be focused this way. There's three different columns on here, and what I'm trying to differentiate is how do people get paid in this particular environment? What are they typically focused on? And what are some of the constraints that they're under? So this is one that looks at your primary care physician, and we have nurse practitioners on here, but sometimes you'll hear them referred to as mid-level providers. And this could be a nurse practitioner or it could be a physician assistant. They're both trained a little bit differently. PAs, or physician's assistants, typically they complete a general course and then they select the area that they want to study in, similar to a doctor. So they may say, I want to work in orthopedics. And then what they do is they get a residency with an orthopedic physician in the office. And that's how they learn their trade. Nurse practitioners are trained on a more holistic perspective. So nurses tend to look at the entire person, not just your broken femur or your broken wrist. We take in all of your psychosocial issues or concerns that you might have. We look at your overall health. We assess all of your body systems, and we really do provide more of a holistic, comprehensive plan of care. Both are able to do things probably equally as well if you need stitches or you need an injection into a knee or something like that. But if you're looking for someone, and I know I'm probably biased because I'm a nurse, but if you're looking for someone truly who is holistic, nurse practitioners are usually more focused in that way. What happens in terms of payment in these offices is they bill for their evaluation of you and the amount of time they spend with you. It's called an E&M code. And there are 4 different levels of E&M codes. So the more time they spend, the more that they can get reimbursed. They also get bonuses, just based on what I was telling you from the previous slide, if they meet certain quality requirements. They also get bonuses for the use of technology, like the use of electronic medical records. And depending upon who they work for, whether it's themselves or a major healthcare system, they get bonuses based on the amount of throughput in their office. So that's why time is one of those constraints that they face.
Can I ask a question?
Absolutely.
It's kind of back to earlier when you were talking, but I was wondering about with Medicare, whether it's a supplemental insurance or the Advantage plans. Does that make any difference in the care that you get? And, you know, or do you address the differences there?
It does make a difference. Typically what we see with Medicare, and this is, just so you know, I'm gonna provide you just a disclosure. This is not necessarily our deep area of specialty. If you have questions about Medicare, we always advise you to call a SHIP, S-H-I-P, as in the boat, a SHIP counselor. These are people that are, well, they get paid by Medicare, but there are people there that you can call that are SHIP counselors, and they know every detail about every insurance plan. But at a very high level, Medicare Advantage will offer you typically a lower premium to pay, and they will have a higher deductible. They also will limit you in terms of the areas where you can seek treatment. So you can be either in network or out of network. And it's very important to understand that particular difference. So if you're someone that lives in Charlotte, maybe in the summertime, and you go to Florida during the winter, you would want to make sure that your healthcare plan is going to cover services for you when you're in another state. The other thing that they do is they don't necessarily pay the providers, physicians, rehabilitation areas, the same amount that Medicare does. They typically pay less. So why is that important? That's important because if you're in rehab and you're a Medicare Advantage person, they're typically earning less per day by having you in that bed than if you were a Medicare patient. We would like to believe that they're all going to just work according to the plan and discharge you when you're ready. But money is a big motivator. So if they know that they can fill that bed with someone else at a higher per day revenue basis, they might try to rush you through a little bit faster than they would otherwise.
Thank you.
Specialists are a little bit different. So specialists, orthopods, cardiologists, surgeons, etc., they still get paid on a time and evaluation perspective, but they also have what's called a procedure bundle. So let's say you get a knee replacement done by Ortho Carolina. That Medicare payment or insurance payment is going to pay for your entire bundle of care. So that's going to include any kind of pre-op care that you get, whether it's going to a class at Ortho Carolina to know what to expect. It's also going to cover the surgical operative component. It's going to cover your hospital stay, and it's going to cover home care or physical therapy on the back end. And there's only so much money in the bundle, right? So the incentive on the specialist is to keep their costs low in all segments of that healthcare component so that they get the most revenue that they can from the bundle. Their focus, a specialist, I'll call them myopic because they are. They, don't ask them if you're there because you had a knee replacement and you're 6 weeks post-op. Hey doc, I ran out of my eye drops and I have glaucoma. Here's the bottle. Can you order this for me? No, they're not going to do that. They focus on one thing. And if you ever look at an orthopedic group, you'll really understand it because they focus on things like wrist, ankle, knee, hip. You're not going to find an orthopod that focuses on every joint in the body. Some of the constraints there, sometimes they are constrained because now Medicare has put in place things to encourage them not to immediately jump to a surgical procedure. So if you go there with back pain, for example, they're required now to say, have you tried physical therapy? Have you tried this? Have you tried that? And it has to be documented because then if they want to take you to the operating room and replace your hip, they have to be able to demonstrate with Medicare that they've already tried those less aggressive, therapies at a lesser cost. Does that make sense? One of the other things is they're always trying to avoid unnecessary studies and treatment, because that's how they're going to get dinged in a negative way from the insurance providers. If they over order on some of those things, the insurance is going to say that it wasn't necessary. Anybody have any questions before we move on from the physician side? Okay. So now we get to emergent care. Couple of different settings here. Urgent care, you're all pretty familiar with urgent care offices. They are here in the Charlotte area. Most of them are open until 8 p.m. I know Atrium just recently opened an urgent care, which is down on Kings Drive, which is open 24 hours a day. Novant, I believe, has a couple of those too, but for the most part, they close at 8. They're there to treat non-life-threatening injuries. You can go there with lacerations to get stitches. You can go there if your primary care physician's not in the office. You're probably not going to see a physician most of the time. You'll probably see either a physician assistant or a nurse practitioner. And they're going to be the ones, like I said, for the non-emergent kinds of things. They're also the ones that you want to check if you're thinking about going there. What's the wait time look like? And now even, I think both Novant and Atrium have the ability that you can actually schedule a time at the urgent care. So you can say, I don't want to be seen until 2 o'clock this afternoon, and that holds you a place. So that saves you time waiting in the waiting room. Freestanding emergency rooms, there's a couple of these around town. Atrium has a few, and I know Novant has a couple. This is more robust in terms of the diagnostic equipment that they have. So they can treat you just like an emergency room that doesn't handle major trauma or, life-threatening conditions. They have the diagnostic equipment. They'll be able to do all kind of x-rays, CAT scans, anything that you might see in a typical emergency room. What they won't be able to do is treat you if you've had a massive head injury or you've had a really bad fall and you're an older adult, because you're at high risk for brain bleeding and things like that. But they can also help by getting you transferred to a hospital. These are more robustly staffed with physicians. In the hospital emergency room, I'm sure all of you have been to one of those. It is what I call managed chaos, because that's exactly what it is. It is chaotic. It is loud. You have mixed groups of people there. You have some that probably could have benefited from a primary care doc, but they don't have one because they're not insured. You also have major life-threatening illnesses coming in constantly through medic. So, if you're not truly in a life-threatening situation, you might wind up waiting for quite some time. Again, if it's not life-threatening and you feel like you have to go to the ED, we always want you to go immediately, and make sure that you don't, underestimate the severeness of what you might have. Any questions about EDs or urgent care?
Now, how do you know if it's a freestanding ER?
Right now there's only 2. There is one at South Park, and it's an Atrium facility. It's right off of Fairview Road, right before you get to the intersection where the South Park Mall is. And then the other one, you said, Elizabeth, Steel Creek is another one. So those are the only 2 that I am aware of here in Charlotte right now.
So if I was with Novant, I wouldn't go to one of those, right?
You could. I mean, if you have insurance that allows you to do that, yes, you can. Again, one of the downsides, if you are typically in the Novant system, you will not have those medical records in your chart as quickly electronically as you would otherwise. Novant and Atrium do have an agreement, and they do share data now, but it sometimes takes a little bit longer to get that information into the chart if you're out of your normal network.
Okay. But if you thought you were having a stroke or a heart attack, would you go to there, or would you?
I would go straight to the emergency room, without a doubt. Hospital emergency room. Yep.
Okay. Thank you.
So which hospital?
Oh, I can't answer
CM
that question.
Is it a Carolina Medical or Novalt?
You know what, I can't advise you on that. We've had experience with both healthcare systems, and you know, if you're with Novant, my clients that I work with that are consumers of Novant healthcare love Novant, and I find the same thing in Atrium. As a advocate, I can tell you that there are some differences in terms of my experience in those systems. One of the things that they have at Atrium, which is very beneficial and very hard to find, is they do have geriatricians that practice in their emergency rooms, and that is extremely helpful. We are always working with older adults, and older adults typically have more chronic conditions that need to be managed, and sometimes they have cognitive impairment. So having a geriatrician there that can manage all that complexity and be able to separate kind of the wheat from the chaff in terms of what is really, really important for my mother to have today versus what is just maybe something that's on a list that I'll make a check mark, but might cause her pain and being uncomfortable. They have a really good way of working with those clients and their families to help them.
No, I'm talking about heart condition. If you have a heart attack.
Can you give me a plug? A plug? You know, I'll be glad if you want to give us a call. I can share with you some of the experiences that I've had. One thing I tell people is if you have a condition and you want to know the best place to go, I would advise you to take a look at CMS Compare, and that's also something we'll get out to you. So CMS stands for Centers for Medicaid and Medicare Services. It's a government website, and anyone who receives payment from Medicare has to publish quality data on that site that you as a consumer can go and look at. So what you want to do if you have a heart condition, you would want to go and you would want to look at Atrium and Novant, and you would want to look at their outcomes for heart disease, whether it's congestive heart failure or it's cardiac surgery. And it's going to show you how they ranked in terms of those quality scores. The other thing I always emphasize when you're trying to decide who to see, particularly in those areas, is if you're going to have surgery, I would pick the provider who's done the most of those procedures and who has the best outcomes. And I have a whole separate checklist that I can go through, and maybe this is a future session about how to pick the right surgeon, about what to look for, where to find information, how do you as a consumer know that you're picking the very best person that you can pick. But it's more than I think we can get into on the call today. So volume is a key, because what they do is procedural. They do it with their hands and with equipment. The more you do with your hands, people that knit and crochet, the more that you do, the better you are. But they also have to keep up with technology. That's another thing. So those are two things, volume and look at their quality scores out in the government website. Does that answer your question?
Yes, she said.
Okay.
What was that government website?
Yeah,
Yes.
we're going to send it to you. Jane will give us your emails, and we can send that to you, and we'll make sure that you have it.
Thank you.
You're welcome. So in the hospital, so what the hospital is trying to do, there's usually a couple of people taking care of you in the hospital. I can remember when I would go, you know, when my grandparents or parents would go to the hospital, usually their family doctor who they saw on the corner of, you know, Mulberry and Maine would be the one that would come in and see them. Well, that doesn't happen anymore. Primary care physicians don't visit the hospital. What they have now in hospitals usually are internal medicine physicians or family practice physicians who are trained as what they call hospitalist. And what the hospitalist does is they manage you, your overall, not your condition necessarily, but they manage your stay in the hospital. They are essentially a coordinator of your care with other physicians. And what they're incented to do is to keep things moving along for you so that you can get out of the hospital in the safest, healthiest manner possible before your insurance company says we're no longer going to pay for any more days for you in the hospital. So their emphasis And the way they get paid and incented, the hospital is going to say to Dr. Hostetler, Dr. Hostetler, we saw in the last quarter that you lost us X number of dollars in revenue because your patient stayed too long in the hospital. We need you to be able to get those patients moving through our system faster in order for you to receive a bonus. That's different than how other doctors, such as specialists, are going to get paid. Because if you're in the hospital and you have a heart condition, the hospitalist is going to be there. They're going to see you every day, but the cardiologist is going to be the one that's ultimately going to say when you're ready to go home. And the cardiologist gets paid every time they walk in to see you, no matter how many times it is or how many days it is, unless it's a procedural thing and they're on a bundle payment. But you see the difference. So the hospitalist is focused on how fast can we make this go, and the cardiologist is saying, well, I don't know, maybe we should try her on this for another day, see how she does. So that hospitalist is incented to work with the cardiologist to say, come on, doc, let's go ahead and get these orders in. Let's get her started on this other thing. We can see how she does, and then we can evaluate it the next time you round. They also work with utilization review, which is a whole office or department within the hospital. These are folks that are specialized in insurance reimbursement. They go around to what they call high risk from a non-payment or not getting a full payment perspective for patients in the hospital. And they are working with the hospitalists and the doctors to say, Medicare is only giving us 4 days for this. Where are we? Do we need to get more days pre-certified? What do we need to do? Are we going to make the discharge date? And I think that's all I really wanted to cover on that slide. Questions, comments, experiences with hospitalists or being in the hospital in general?
When my husband was in the hospital, they were saying that they had to do something for Medicare to pay that he doesn't come right back, that he be discharged and not have to return.
Yep. I don't know how many years ago it's been now, but Medicare implemented a rule that if you are readmitted back to the hospital within 30 days of a discharge, that they will not reimburse the hospital for that second hospitalization. So what they're trying to do, it gets back to that whole quality component. They're trying to make sure that before you get discharged, that you're in the very best shape, and also that the physician has done the diligence to get you set up with the right post-discharge care, whether it's physical therapy, whether it's rehabilitation, whether it's a follow-up back to your doctor's office to check to see what your weight is because you have congestive heart failure and if you're taking your medications. And it's only true for a couple of categories: heart, typically joint replacements, diabetes is one of those conditions, stroke, hypertension. So hospitals are doing everything they can to make sure after you leave that you are safe, you're following the doctor's recommendations. Both hospitals now actually have telecenters where they have registered nurses contacting these folks on the phone after discharge and following them after discharge and checking in on them, maybe sometimes once a day, maybe a couple times a week, and helping them to overcome whatever kind of barriers somebody might have. Like maybe they say, I can't afford my medications. So then what that case manager does that works for Atrium or Novant is they start working through what kind of options they might have to get that patient either discounted medications or medications through another mechanism so that they can afford to take their medications and remain healthy and at home.
Thank you.
Again, getting back to my point earlier, the hospital system was not set up to make your stay pleasant. It was set up to make your hospital stay efficient for the healthcare provider, the physician. Keep in mind that hospitalists often see and cover, depending upon the shift, if it's night shift, they can cover up to 40 patients during the night from 7 p.m. to 7 a.m. During the day, that ratio is lower, of course, but it's still a huge workload that they cover. So they are seeing a lot of patients. They probably are not going to be there when your specialist rounds, but they are going to, look at the notes and see what the specialist wrote. Doctors tend to make rounds at their convenience. If you're in the hospital because you had a procedure like a total hip replacement, most likely if your doctor has OR that day, they're going to come around 4:30, 5 o'clock in the morning. Well, guess who's not there at 4:30 and 5 o'clock in the morning? None of us, none of the families there, right? So you may say, wow, how am I going to get in touch with a physician? Well, that's where being an advocate comes in, and we have suggestions on how you do that. Because keep in mind that these individuals are your hired employees. And now doctors wouldn't want to hear me say that because they don't want to be referred to as employees, but that's what they are. We hire them as a consumer to do a service. And you have every right as a consumer to ask questions of your physician and to get the information that you need. Weekends, don't ever schedule a procedure for a Friday. Weekend staffing is not the same in the hospital as it is through the week, or even Thursday. And doctors may change. Your specialist may have a different rotation for on-call over the weekend, and it may not be that person that operated on you. So we always try to encourage our clients to schedule things early in the week. That way we know, we have a little bit better assurance anyway, that the doctor that did the surgery is going to be the one that at least sees you in the hospital. The other thing is hospitalists, they usually work 7 days on and 7 days off. So they're there either from 7A to 7P, 7P to 7A for 7 consecutive days. And most of them switch rotations on Tuesday morning. So if you go to the hospital on Thursday and you've been seeing Dr. Smith Thursday, Friday, Saturday, Sunday, Monday, come Tuesday morning, Dr. Dodger is going to be in there. And Dr. Dodger has to rely on reviewing all the notes and from a face-to-face handoff that he did with that off-going physician, Dr. Smith. But, that's another continuity of care kind of thing. And that's where, as healthcare advocates, we often help to kind of fill in the gaps because we know so much about what's going on with our clients. We can usually help the hospitalists get a better, fuller picture and kind of keep them on track with, okay, this is what we understood was going to happen today. Do you have that order written? The other thing that's important when you're hospitalized is understanding who's in charge from a physician perspective as well as a nursing perspective. Because if you're not satisfied with something, or maybe the nurse just isn't the right personality for you, it's okay. Personalities are personalities. Sometimes they mix and sometimes they don't. But if you've got a concern, you need to know who's in charge in the hospital. And there's a hierarchy for who's in charge. But that's important. The person that's going to be visiting you in the room is the care nurse. There's also a nurse aide, most likely. There should be a whiteboard in your room where they list their names and their number. And ideally, there should also be a number on there for the nurse manager or the charge nurse. That nurse manager or charge nurse is the first one you should go to if you have any concerns. If they can't satisfy your concerns, then you kind of go up the chain and then you ask the manager, can I speak to your supervisor? Just as you would if you were unsatisfied at the Walmart, right? You try to return something and they don't want to take it back. Questions before I move on? So when you leave the hospital, that discharging physician, the hospitalist, he's going to write the order, but he's writing it under the advisement and guidance of the specialist. So he's going to make sure that they transcribe everything that the specialist wants you to do. They may also decide that you might need to go to rehabilitation, or you might need outpatient physical therapy, or you might do better if you had some home care. Maybe you're going home with a complex wound that has a dressing on it, and home care might be consulted to come in and change that dressing for you every couple of days. Keep in mind with all of this, no matter what hospital system you're in, whether it's Atrium or Novant, you as a consumer can decide if you want to use Atrium or Novant services, or if you want to use somebody else. And there are differences in services. Those websites that I was telling you about are right here. You can look at them for home health. You can look at them for nursing homes or rehabilitation. And when you look at rehab, you look at short term. When you look at skilled nursing facilities, they'll have two measurements. One is for the long-term care patients. These are people that are, have multiple chronic conditions, require the constant oversight of a skilled nurse, which means a registered nurse according to the government. And these are people that are in what I would call a traditional nursing home. The short-term component that they offer is rehabilitation focused. So that's why it's important to go out and look and see what their quality scores are for short-term patients. What I've found in our experience is the nursing homes that do a really great job with their long-term care patients often don't do as well with their short-term patients, and vice versa. So it's important, if you know you're going to go in for a procedure and you know you're probably going to go to rehab, maybe because you live alone or you can't drive or whatever, take a look and make sure you know and you have a good idea of where you want to go for rehabilitation. The other thing that I didn't list here, that government website is also available for hospice care. So you can look out and see how the hospice organizations in your community rate in terms of quality and satisfaction. I'm sorry?
Same for the hospital.
And same for the I didn't include, hospitals are also on here as well. So you can go out and research, like I said, Atrium, Novant, and you can see what their quality outcomes look like. Post-acute care, this is a big area, and oftentimes we don't talk about it enough, and it's way more confusing than the other areas I've explained so far, just because it's regulated differently. So if I look at home care, that might be a nurse aide that needs to come in, I don't know, maybe 3 times a week and help someone bathe. These agencies don't provide and they don't employ any registered nurses that come to see the patients. So they are regulated by the state Department of Health and Human Services. Home health care has skilled nurses. They come out to do dressing changes, administer IV antibiotics, maybe assess a wound, etc., do teaching, things like that. They are reimbursed by Medicare. Therefore, you will find their quality outcome information on the CMS websites. Rehabilitations and skilled nursing cares are both under the federal government from a regulatory perspective, as well as a state, but they really report directly to the federal government. They post their quality scores. Palliative care and hospice, usually if you're working with a palliative care group, the palliative component and the hospice component, it's usually a combined department or service. So oftentimes you won't hear them necessarily differentiate, but palliative care, particularly for clients or individuals who have a lot of chronic conditions that need to be managed, what palliative care does is they really focus on quality of life, maintaining your health and improving it, but they're heavily focused on symptom management. So if you're a chronic pain patient, or if you have chronic congestive heart failure and your quality of life has gone down, palliative care is really focused on how do we better manage your symptoms so that you can feel as good as possible every day. And that's sometimes a service that's often overlooked. So if you know anyone that has, you know, a scenario like that, you know, it may be beneficial to ask the physician, do you see some benefit in working with palliative care? And keep in mind that if you ask about working with palliative care, it doesn't mean that you're giving up your primary care physician. That is an adjunct to the primary care physician. And one thing I will tell you is if you work with a physician and they tend to be negative or say, oh, you don't need that, or this isn't important, I would advise you that that is probably not a great physician. A great physician is one that wants to work with other physicians and they want to collaborate with other physicians. And ultimately, they want to give you, your family, the best quality of life that you possibly can have. So that's a red flag for me. If somebody just, you know, poo-poos an idea, or a physician who says, like an orthopod that says, oh, you don't need any rehab, you'll be fine. Well, no, that's not true. You don't want to work with that surgeon. Questions, comments? So home health, just a couple of short things. They're typically pre-certified for a couple of visits. So if you have an IV in and you need to get IV antibiotics, they'll go out and they'll administer those IV antibiotics. But once that IV's out and you're done with that round, they're not going to come back to see you unless there's another need to. If there's another need, that means they'll have to go back to the physician and have them get pre-certified for some more visits. But the insurance companies are very, very stringent on how many visits that they will allow a home care agency to do. As I said before, they tend to focus on IVs, wound management, therapy, OT, physical therapy, speech therapy. And again, they're constrained because they just don't have the fluidity of coming out all the time. But they can come out to do certain kinds of tasks and help you with therapy types of things. And often, not all care is covered for home care. So it's usually those task-based things that require a skilled nurse to oversee. Rehab, Medicare will cover, this is like, I'll give an example, Sardis Oaks, which is over here off of Fairview Road. That is considered a skilled nursing facility. They also do rehabilitation there. So if you went there after your total knee replacement for therapy, Medicare is going to cover the 1st through the 21st day at 100% for you. And then you start co-paying at 20% on day 22. So what we find is the rehabs work according to the insurance schedule. So when I talk to rehabs and say, when do you anticipate Adrian's going to be discharged? They'll say, well, she's covered at 100% until this day. If that day comes and you're not fully up to par, they're going to discharge you, no matter where you are. They're also going to try to discharge you if you're in there and you're not making progress on your rehab. If you are in a rehab facility and you are there within the first 21 days and they're talking about discharging your mom or dad because they're not making progress, you need to call a healthcare advocate, because there were laws passed a number of years ago that deny them the ability to discharge you because you're not making progress. And I or other healthcare advocates know about that, and we can also get you in touch with the right elder law attorney that can look at that and determine if they really have any grounds for discharging you or not. You're there because they want you to meet certain physical goals. So if you're a total knee, they might say, we want Adrian to be able to walk down the hall unassisted with a walker at 150 feet. We want her to be able to fully dress herself, fully bathe, clothe, etc. So that's how they kind of measure your progress. I'm sorry. Questions? So skilled palliative and hospice. This is our last slide. So I'll go over this at a very high level. Any of you ever had, well, I know some of you had, I know Jane just recently had a very tragic experience with her mother-in-law in a care community. Anyone else ever had any family or friends in a care community? I'm sure you probably have. What we tell everyone is you have to make sure if you've made a decision that you can no longer care for someone at home, and it's hard to care for somebody at home. Being a caregiver is a very difficult job. And it's expensive, especially if you need outside help. And, you know, many people say, especially with people that have cognitive impairment, I just can't keep up with them anymore. I can't manage things. I don't feel like they're safe. And they make decisions that they have to be moved into a care community, and that's okay. But keep in mind that once they're in that care community, you still have to be ever present. Somebody from the family or somebody from a social circle has to be in and out of that facility on a very frequent basis. And you have to get to know the staff, because it's the squeaky wheel concept. The more you're there, the better the care is going to be for the person that's there, that you're visiting. And I hate to say that. I wish I didn't have to say it. I wish I could say that, you know what, you can go there and you could go on a 2-week vacation and your mom's going to be fine, but that's not the truth. It's just not the truth. They're underfunded. The people that work there aren't necessarily always skilled, meaning they might be nurse aides and recreational people, or maybe they're a nurse aide that has a medication administration certificate, but they're not going to be treated like you would see somebody being treated or evaluated or assessed in a hospital setting.
Is that true also for like retirement places locally here, plantation estates for one?
Yeah, I haven't had any experience with plantation estates. Some of those communities, and I think plantation estates is one of them, that's called what we refer to as a CCRC. That's a continuum care retirement community. And what that means is they've essentially built out all those different aspects of care that someone might need. So they have independent living, they have assisted living, they have memory care, they have rehabilitation, and they also have skilled care. And we have a number of those in Charlotte. Plantation Estates is one, the Cypress is another, Southminster is another. A lot of folks like to buy into that, and there are pros and cons to that, and that's probably a whole nother workshop because there's a lot to know about that. And then there's other community care areas like the Walton Woods. They have assisted living, independent living, as well as memory care, but they don't do any kind of skilled care. Same with Sunrise on Providence, or maybe Brighton Gardens, or places like that. So yeah, I would say that that is the case in those areas. Now, if you find that, you know, at Plantation Estates, I can't speak on their behalf, but if you find that you're going in there very frequently over a long period of time and you're very satisfied with the care, that's fantastic. Consider yourself lucky. And I'm not trying to downplay or degrade the care that's provided. Some of these places do really provide very good care, and some of them not necessarily. So it's kind of buyer beware on the front end. And what makes it hard is if you're moving to a memory care unit, you can't find that same kind of publicly reported information that you would if it were a skilled facility, because it's state regulated. You can find what their surveys yielded in terms of medication safety, food management, food safety, but you'll never find scores on how many of your people become incontinent within the first 6 months, how many of your people are on antipsychotic medications to manage behavior. And that's the hard part. That's where it's important to get in touch with someone who's either had experience at that care community or a healthcare advocate that knows that healthcare community. Prior to the quarantine for COVID, Elizabeth and I were in and out of these communities on a weekly basis. So we, as of March, knew what the care was like in those communities. Right now, we have no idea. Many of those communities, their staff has tested positive for COVID, and of course, they're not working. So they might be bringing agency staff in. Agency staff are fine, but they don't know your mom and dad like the caregiver did that worked there originally. And it's frankly, I was talking to Jane about this before everyone got on the call. It's a very scary time. And, you know, I would encourage you in this time where things are not transparent to ask questions, to prod, to poke, to push as much as possible to get window visits or FaceTime visits, or talk to a staff member that you know off the record and ask, how are things going there? And just make sure you've got as much information as you can get.
Let me just add, since I have just experienced this, don't hesitate to call the palliative care consults. They can tell you no, but you don't have to be, you know, there are certain requirements for them to be able to take it on. But first of all, it's free. So a lot of people don't realize that. There's no cost to you for hospice and palliative care. But don't hesitate to call and ask to be evaluated or talk to the physician, you know, and they should be supportive of it, but they typically won't bring it up. I have experienced this more than once, and sometimes they'll even be no, they might even say no, but I waited longer than I should, but as soon as I did it, they immediately jumped in, and this was actually even during the lockdown. So they are actually allowed in a limited basis, most of them. Mm-hmm. So that was the only reporting I was getting other than from the nurses, and it was much better. The nurses were like, yeah, everything's fine. And it really wasn't fine. And I didn't really find some of that stuff out. So I encourage you, if you have someone in, you know, or yourself, I mean, you know, it's palliative care is, and they, in terms of hospice as well, my father was in hospice for 3 years with end-stage kidney failure. He was still running around town playing cards, doing stuff, but he qualified for hospice. So, and he lived for 3 years after he got on hospice. So, you know, don't assume that you have to be dying to take advantage of these services, and they're phenomenal. So I can't speak highly enough about my experience with palliative care and hospice both. And hospice likes you to kind of be in palliative care first. So they have, you know, so you sort of transition over if necessary. And you can also come out of hospice care. It's not, you know, it's not like you go in and some people actually get better. So there's a lot of preconceived notions about what it is. And I just encourage you, if you have questions, to look into it. Don't just assume it's not the right thing.
So Jane, are you saying you had palliative care for somebody that was in a long-term care facility? Is that
Yes.
what you're saying? Okay, thank you.
And with Alzheimer's particularly, a lot of times you will not qualify for hospice, but you will qualify for palliative care. It just really depends on your abilities and how well you're doing your certain functions. So there's checklists. So you may not qualify for one, but you may qualify for the other.
Okay, thank you.
Thanks, Jane, for sharing that. I couldn't have said it better myself. A lot of times I think we wait too long to consult palliative and hospice care. Numerous studies for many, many years have demonstrated that people receiving palliative and hospice care have an improvement in their overall quality of life. They usually have better symptom control, better pain management, quality of life. And as Jane said, they can be discharged. Elizabeth and I both volunteer for hospice. I've been working with them for 5 years. And I've seen a number of my clients that I contacted by phone be discharged from hospice alive. And it's great. Medicare covers all of it. They'll cover the medications that relate to the condition that qualifies them for hospice. You can get equipment that's Medicare funded. You can get, you know, a variety of things. You never have to take your loved one back to the doctor if you're under hospice care. The doctor will make a periodic visit to see them wherever they are, in your home or in a skilled care facility. And the nurses come out, depending upon the condition, as often as 3 times a week. If someone's, you know, in the process of transitioning, is what we refer to as if they're, you know, actively progressing toward death. But it's a very, very good service. And I think the name hospice, I think we really should rebrand it, because people have such a negative connotation about what it is. But it's a great service that people often don't think of until it's very, very late.
They're angels. That's what they are. They're angels.
I agree.
It's a special calling for a nurse.
It is.
Yeah.
Well, Jane, I'm sorry to hear that you've had some recent difficulties with Dave's mom. I've been kind of on a cycle with my dad. He's 99. I have him living at home. I have people coming in to do all his meals and take care of him. He's cognitively with it, but every time he falls, we go through rehab. We go home with home health care, PT, OT, you know, the whole gamut. Mm-hmm. He meets his goals. You've heard this before. He meets his goals, they leave, and then he regresses. And I can't seem to get, I had hospice, but they determined that he didn't need any of it, other than having a nurse come maybe once a month to check his blood pressure. So I'm not sure where to turn to try to just get, I guess something I'm looking for is more preventive, and nothing's going to help me, I guess, with that, unless I hire my own physical therapist. So I don't know if anybody's been in that situation or not, or you could give me any tips on that.
Well, understanding the cause of the falls, right? Safety is probably the number one thing. There are people that do in-home safety assessments. I actually work with a colleague who is a concierge physical therapist who does in-home safety assessments and also provides in-home physical therapy.
That was last week's seminar.
What's that?
was last week's seminar.
Well, I missed it. I
Oh.
couldn't, I'm sorry. I didn't realize that. Well, we have had that before, but he keeps getting dismissed. So I don't know what to do.
Well, typically,
I'll look at last week's seminar is what I'll do. That's number one. That's the first thing I'll do.
Connie, the other thing you can do is if you want to give us a call after this, we can talk to you more specifically about that situation because I understand that your insurance company or Medicare is going to discharge him at a certain point, but he can still have concierge physical therapy and pay for it out of pocket for as long as he wants or you want. And then the other thing I would just add to that is probably considering palliative care, just because of his age and frailty. He probably could benefit from a palliative care physician working with his other doctor.
Okay.
But feel free to give us a call. My number is 704-517-9006.
9006. Okay.
Yeah, and we'll send that out to everyone once we get the contact information from Jane. But in the process of finishing up, this is the last slide. Anything, well, actually it's not, the key takeaways. So this is all the things that we've talked about. Seek information. Don't feel like you're bothering people. If you miss somebody during rounds, have them paged or have the nurse put a note in the chart, say, call me at this time or give me a time that you can talk to me. And remember, if you ultimately are not satisfied with a care provider, you have every right as a consumer to find someone else, and it's okay. So with that, that's really the content I have to share today. What kinds of questions or other points can I help with?
Anybody have anything?
Well, I'd like to have you come back and talk about long-term care places.
Okay. What would you like to understand about that?
Well, I'd like to understand the differences in them, and is that a good option for someone for future years of, you're paying for your health care and to be taken care of, and is that the best setting?
Sure. Yeah, we've done workshops like that before. So if Jane would like to accommodate us, we can certainly do that. Sure. Anyone else? Well,
This was great information. Thank you so much for sharing it.
You're welcome. And thank you all so much for your time and attention. And thanks for attending today. It was a real pleasure.
Yeah, it was great to see you guys. Next week, we've got the library coming out. So the library is doing a bunch of programming and virtually, obviously. But I think you can also still get books out and doing some Ancestry.com things. So lots more resources to kind of expand our minds and learn how to use some new resources. So I'll look forward to hopefully seeing your faces. Please spread the word. Our numbers seem to be dwindling, and I'm not sure whether people are just busy with other things, but you don't have to be a Y member. Some people have even left their membership for obvious reasons, which is understandable, but this is sort of open for everybody now. So if you have friends and family, the Y has no walls. We're just trying to be there for people and create community and send out information and just do our best to connect. So please encourage other people to check. I send out emails every Monday. Hopefully you guys are getting it with the upcoming programming, but we'd love to keep this going as long as people want. And I'm always looking for ideas. If we've got an idea for Cindy and Elizabeth to come back from Care Weavers with us, and I'd love to make that happen. So we'd love to see you guys some more.
Yeah. Thank you so much. Great question.
Thank you.
All right.
Thanks, Jane, for everything.
Thank you.
Thank you guys.
Bye-bye.
Bye.
Thank you.
Bye.
Thank you.
Cindy and Elizabeth, you want to hold on for just a sec?
Fast.
A little fast.
It was a lot of information. I just needed to.
Are you feeling okay?
Yeah, so Desiree wants to do this. It's called a capstone call. It's the last thing I need to do before I can go out into the field. So be okay if I start that now? She said it'll probably take us about an hour and a half.
Do you gonna need your computer?
I can use that one.
That'd be good.
Yeah,
Guys,
that's
I just want to say thank you so much. You there? Elizabeth? Elizabeth, you there? Hello? Elizabeth?